Much for coming. We have a massive crowd tonight, so thank you for coming out, and it's going to be a really interesting presentation. I've not heard this presentation either, so I'm excited to hear it. I'm Sue Gillerlane. Some of you are familiar faces to me, but I'm the Program and Outreach Coordinator at Living Well. And can't hear? Oh, sorry. Actually, you know what? I wonder if you might need. I will speak up. I'm the Program and Outreach Coordinator at Living Well. My name is Sue Gillerlane, and thank you very much for coming tonight. Can you hear me now? Is it better?
Yeah.
Okay, good. And just a few things. I want to introduce Dr. Grimm. Dr. Grimm specializes in neuro-oncology at the Northwestern Medical Regional Group. He received his medical education from the University of Texas Health Center at San Antonio. He did his residency at the New York Presbyterian Hospital on Cornell's campus. And he did his fellowship at the Memorial Sloan Kettering Cancer Center in New York. His clinical interests include the treatment of brain tumors, metastatic central nervous system tumors, and the neurologic complications of cancer and cancer treatment, which he'll be talking about tonight. His research interests include designing and conducting clinical trials for patients with primary and secondary brain tumors. So he is quite accomplished. Just want to introduce Dr. Grimm, and also want to remind you that you have a survey in front of you. So after the presentation tonight, please fill that out, and you can leave it on the back chair before you leave, or you can see me drop it off over here as well. We also have, if you've never been to Living Well before and you'd like a packet, a new member packet, I have several at the front. So feel free to grab a new packet, see me afterwards, and we can make sure that you have all the information about Living Well. And lastly, just want to remind you, follow us on Facebook. We have a lot of updates that come out, and you can find out what's going on program-wise and services that we offer at Living Well CRC. So with that, I'm done. Thanks again for coming, and Dr. Grimm.
Great, thank you for having me. It's a very important topic, but it's also a topic that, unfortunately, I don't think we have a lot of great answers for. I'm going to do this presentation, but there'll be some time at the end if anyone has questions that they want to ask. Okay, so I was asked to talk about the effects of chemotherapy and radiation on the brain, in particular the effects that it has on cognitive function. And that's what I'm going to be going through. So I'm going to start by just going through a case of a patient that I took care of in the past. And she was a 45-year-old woman who was diagnosed with breast cancer. She was treated with 4 cycles of chemotherapy that consisted of doxorubicin and cyclophosphamide. And these are just 2 chemotherapy drugs that are commonly used for breast cancer. During treatment, she experienced fatigue and had difficulty concentrating and multitasking at work. As part of treatment for breast cancer, another chemotherapy was added as part of her standard treatment, and that chemotherapy is called paclitaxel. That was started, and then she began having trouble recalling names and words and couldn't finish even simple tasks. After 3 cycles of the paclitaxel, her cognitive difficulties were so severe that she had to take a leave of absence from work. She told friends that she felt like she was in a fog that wouldn't lift. Her doctors were concerned that the cancer had spread to the brain, so they did an MRI, which came back normal. They sent her for neuropsych testing, which are, I don't know if anyone's ever had this before, it's like a several hour-long testing where they test different aspects of memory. That came back normal. So the doctors, were concerned, what is actually going on in this case. And most likely what she was experiencing is something we call, or sort of colloquially called chemobrain or chemo fog. And this is something that cancer patients will complain of. It's often a mental fogginess or brain fog. Basically, it's often kind of a vague complaint, meaning it's just kind of a generalized complaint. It's distressing change in their thinking, alertness, and mental function as compared to their prior baseline level of functioning. This can interfere with patients' work. Some examples include taking longer time to complete tasks, trouble recalling names or objects, trouble focusing, trouble multitasking, difficulty finding names or words, diminished ability to learn new things, and forgetting to finish small things like turning off a light or locking a door. When we think about this actually has multiple potential causes. The cancer itself can cause some cognitive and memory issues due to the effects that it has on the body, as well as if it metastasizes to the brain or to the spinal fluid. Patients with cancer often get radiation therapy. That could be radiation therapy to an area of their body or to their brain. Obviously, I'll talk a little more later about radiation therapy and cognitive issues, but even radiation therapy to non-brain areas like to the lung or to breast region could cause some cognitive issues. Hormonal therapies can affect memory. Fatigue, most patients who have cancer, whether or not they're undergoing treatment, have fatigue as a big complaint. Other medications that they're on can cause fatigue. This can include steroids, anti-nausea medicines, pain medications. And then there's the issue of anxiety and stress and depression and worry from cancer as well as the cancer therapy that a patient's getting. But let me talk a little bit about this idea of chemobrain. So the first question becomes, I mentioned a lot of potential confounding factors, but is there an association between chemotherapy exposure and cognitive disturbance? And this is a difficult question to look at, but most studies that are out there support the idea that definitely chemotherapy can cause cognitive dysfunction. Then the question becomes, is cognitive dysfunction caused by chemotherapy? How can we know? But there have been animal studies and that have been combined with different types of brain imaging research that has shown that chemotherapy is toxic to the brain and can contribute to cognitive difficulties. Brain imaging studies have shown that patients who get cancer treatment often have abnormalities on their MRI, even if they didn't receive any type of radiation to the brain. Even just getting chemotherapy can cause some changes on brain MRIs that can be associated with cognitive dysfunction. And the animal models have shown that there could be persistent performance decrements in animal models of learning and memory following exposure to chemotherapy, as well as decreased neurogenics and cellular proliferation and increased cellular death in an area of the brain called the hippocampus and the subventricular zone. So I know when I was in high school and even college, we were often taught that the brain doesn't have any cells that divide, that you're sort of born with all the brain cells that you'll ever have in your life, so you better treat them well because over time they'll die and you'll be left with less. Well, we now know that there are certain areas of the brain that actually do have cells that divide. Those are these areas of the brain called the hippocampus and the subventricular zone. And these are areas that have been shown to be important and involved in memory formation. So what is the frequency of chemotherapy-induced cognitive dysfunction? It's difficult to assess. Estimates suggest that it's probably somewhere between 20 to 80% of patients who get treated with chemotherapy develop cognitive issues that's probably related to the actual treatment. The challenge we face as physicians is that there's no way to predict who the patients are that are going to develop the cognitive side effects. You can imagine that if we knew that a patient was going to develop the cognitive issues, perhaps we would lower the dose of a chemotherapy or perhaps switch one chemotherapy out from a different one. But unfortunately, we don't really know which drugs are the most likely to cause cognitive issues, as well as how to predict who the patients will be who will develop those issues. What cognitive domains are affected. So that's another issue that makes it challenging to kind of research this or diagnose it, and that there's no test that we can do to sort of diagnose someone with chemobrain. Meaning, I told you that we sometimes will send patients for what's called neuropsych testing, which is a whole battery of tests that look at different memory issues. The problem we face with that is that often patients who are complaining of cognitive issues after chemotherapy, they'll go through these sophisticated tests and they'll come back normal. So often physicians will just think, oh, well, they must not have any issues, those tests came back normal. but those tests probably do a poor job of testing the actual issues that patients have. And in addition, one of the reasons why they may do poorly on those, do well on those tests, even though they're having cognitive issues, is that the chemotherapy-related neurotoxicity results sort of in a whole generalized decrease in mental processing speed and capacity rather than a sort of focused or focal cognitive deficit. Another question is, what is the severity and duration of this chemo brain? So some patients, they'll start developing difficulty after the first treatment, and others it may develop after subsequent doses. And most of the studies suggest that after the treatment's done, the cognitive issues will improve. Although there is a subgroup of patients who, even after they stop treatment, they never get back that cognitive function that they had before. So in some patients, this could even be a permanent issue. And then one question would be, what is the impact that this has on patients' everyday life? So it could be a significant barrier for a patient returning to work, and it can interfere with daily routine at home as well as with family life. So this has a huge impact on quality of life, and it has a huge issue, but it's often not something that's assessed when patients see their oncologist or at their doctor's visits. So how do we treat this? The challenge is that we've found no medication to truly treat this huge issue. There are non-drug treatments that seem to be helpful. I would say that probably what's been found to be most helpful is exercise. That could be walking, yoga, strength training, although it's kind of variable in how much patients improve. There are some structured cognitive training programs that can address memory, attention, and processing speed. Some of them have been promising, but it's not something that, as a doctor, I can typically refer my patients to. Often these are just available to patients as part of a clinical trial looking at interventions to try to deal with this issue. Sometimes strategies could be helpful to patients. So, for example, we'll recommend that patients keep a daily planner, have a to-do list, frequently update it. We recommend patients do one thing at a time. Only focus on one task, try not to multitask. As far as taking medications, buy a pill box and a pill diary for all medications, because it can be difficult to remember which to take and remembering if you actually even took the medications. Establish and follow routines can be a helpful strategy to take. And then be social, get out amongst people, because again, if people are kind of thinking out, interacting with people, often that can also be helpful. I'm going to move on now to radiation therapy. It's well known that radiation therapy can cause cognitive issues. So basically, all patients treated with brain radiation will complain of some type of cognitive issue. Often what they complain of is short-term memory loss. And it often resembles what's seen by older patients, or as we all get older, kind of the issues that we all experience. But it kind of accelerates that, or it happens at a younger age. So these are things like forgetting names, telephone numbers, appointments, and recent events, but often the more remote memory is intact. 10 to 20% of the time after whole brain radiation, the memory loss can be more severe. And in many cases, that's related to the age of the patient. So often patients over the age of 60 have a lot higher risk of developing cognitive issues. Could also include whether the patients are getting chemotherapy in addition to the brain radiation. And then often patients who are getting brain radiation often have other reasons to cause cognitive issues. This could include the tumor affecting their brain, could include anti-seizure medications, or, as I mentioned, chemotherapy can play a role in this. Because radiation can play a role, we're looking at different strategies to treat brain metastases that try to reduce the risk of developing cognitive issues. So one area I think that's been a major advancement in treating brain metastasis has been the development of very focused radiation techniques. You may have heard of things like stereotactic radiosurgery or gamma knife or cyber knife. These are ways of focusing radiation on a very small area, thereby trying to reduce the exposure of normal brain to radiation. Because we do know that the volume of brain that's radiated and the dose of radiation that the brain gets are all sort of risk factors to developing cognitive dysfunction from brain radiation. Another way that's actually a technique that was developed by one of my colleagues at Northwestern is to do a type of whole brain radiation where we actually try to spare that one of the areas of the brain that I told you about earlier that has cell division and is associated with memory. And that's something called hippocampal brain radiation. And this was it was looked at in a clinical trial where they randomized patients to get standard with multiple brain metastases to get standard radiation versus radiation with this type of hippocampal sparing. And what they were able to show is that patients who received the hippocampal sparing radiation had less cognitive side effects than patients who had standard whole brain radiation. And this is just an example of the radiation dose fields that show how they were able to spare that part of the brain called the hippocampus. So what this is actually showing is these areas in circles are actually, that's the part of the brain called the hippocampus that's associated with memory. And what this is showing is they were able to, by using modern radiation techniques, reduce the dose of radiation to those areas, but then have normal radiation dose to the surrounding areas. So, so this study did show that it did help spare some of the memory and cognitive issues that patients experience. So I wanted to actually stop here. I wish I had more to tell you about this issue, but there's unfortunately not a lot out there. But I wanted to leave a lot of time for questions, because I think often what can be most helpful is a lot of patients have, and caregivers have a lot of different questions. And what I wanted to spend most of the time on is just to try to be available to answer any questions that anybody has. So I'd like to open the floor to any questions that anyone has about chemotherapy or radiation issues on the brain. Yeah.
What are your thoughts about like the herbal things like ginkgo biloba and the different over-the-counter things that are supposed to help cognitive function?
It's a great question, and it's one that I often get from patients. And it's one that's very challenging to answer, because basically none of those products have good studies that suggest they work. There's also no good studies that say they don't work. So it really leaves, as a physician and as a patient, it really leaves us in a difficult situation, because we really don't know. I would say, I think most of the products probably don't do what they say. They often, and not only that, it's often, even if it has an effect, because these are coming from so many different manufacturers, you don't really know the quality of the product, they're not being regulated in any way, you don't truly know if you're even getting what they say on the bottle. So it's a very challenging question to answer. I would say in most cases it probably doesn't hurt, especially as long as you're just taking it at the doses that they say on the product recommendation. But whether it helps, I'm pretty skeptical most of the time. I would say probably most products I think are not, that don't work, and there's nothing that I would sort of routinely recommend to my patients from that standpoint. Yeah.
Is there a lack of research money to support the impact of chemobrain on people?
I think that if good studies or good research could be developed, I think the money would be there, because I think for patients this is a huge issue. So meaning, I think a lot of the large sort of societies, like breast cancer societies, or particularly breast cancer society, because often breast cancer affects young women, often in the prime of their life, and they really, I think, can kind of experience those side effects or report them a lot more than maybe older patients do. So I think the money would be there. I think the really challenge is being able to define what is chemobrain, and being able to define how we can diagnose it in patients. And so I think it's a challenge to do those studies. Two, because it's hard to do that, I think as a physician, we always want to have an answer for things. So when you have something like that that is sort of difficult to treat or diagnose, often people don't even want to get involved in it or try to do it. So I don't think it's a money issue as much as I think it's an interest on the researchers in doing that, to be honest with you. Yeah.
I got here a little late, so I'm sorry if you already talked about this, but are there certain chemotherapies that you see chemobrain with more often? I know, for example, I'm on Taxol every week. I didn't know specific.
Yeah, so it's a great question. And the answer is, we don't really know of one particular chemotherapy being worse than others. But definitely the breast cancer population seems to be one of the most affected groups, where again, Taxol is usually one of the drugs, or often a drug that breast cancer patients are receiving. I presented at the very beginning a case report of a patient with breast cancer, and it was really when she started eating Taxol that she was having a lot of cognitive issues. Whether that the breast cancer drugs or the drugs commonly used for breast cancer have a higher incidence of this, or whether, probably, like I just mentioned, it may just be that it's affecting younger patients on average, patients who are often still working, sometimes taking care of families, so they may notice the effects more significantly, but we don't really know of any particular drug that has more effect than another. We don't think of these drugs getting into the brain very well, so we know that most of these chemotherapy drugs, they don't get in the brain, which is one of the reasons why even when a cancer is controlled in the body, but patients develop brain mets, it's often because the chemotherapy is not getting past the blood-brain barrier. But even this effect that it has on cognition must have something to do, irregardless of whether the drug actually gets into the brain in high quantities or doses. But to answer your question, we don't really know if there's one that's better or worse than others. Yep.
It appears that you're addressing primarily metastatic brain tumors, right? My wife had 2 GBMs, which were, of course, original tumors. She had radiation and then Temodar. She had none of the problems that you're discussing here, but it destroyed her white and red blood cell count to the point that she couldn't continue. The only thing she could continue with was the Optune device. Any progress on things that won't destroy the immune system quite as bad as Temodar?
Yeah, no, it's a great question. I would say for primary brain tumors like glioblastoma, nothing that's come out new other than what her options were at that time. There's a lot of research going on looking at different therapies, like looking at viruses and other things like that. So I would say that we really, for that type of tumor, we don't have anything kind of on the market or new that's come out. For cancer in the body, I think there have been some advances that may reduce sort of the risk of that. I think particularly there have been immunotherapies developed. So immunotherapies are drugs that actually stimulate your immune system to fight cancer. Those may not have as much of the issues on cognition as standard chemotherapy. I think one of the issues with standard chemotherapy is they're basically poisons that we're giving because they'll kill tumor cells, but they also kill our normal cells as well. So, so I do think there are treatments coming out that, at least for cancer in the body, that may be helpful. Unfortunately, I think for primary brain tumors, at this present time, we don't have anything new that.
No progress with the poliovirus?
Again, it's in early stages. It's still in kind of early clinical trials.
Okay.
So there is a virus study that's going to be in a phase 3 study. It's a different virus that's being looked at. But again, that's a study that's going to be opening up in the next few months, and we'll see if there's if that does anything.
Thank you.
Yeah.
I had a question about, you talk about the chemo brain during chemo, but me, it's been almost 3 years since my last chemo, and I do have neuropathy, but then I do still feel like there's differences in my cognition, so can you talk about like any research, like how far out from chemo?
Yeah, so I would say that probably 20% of patients will have issues that go on, cognitive issues that continue even after the chemotherapy is over. And I think we know even less about that because, again, I think the doctors are focused on evaluating patients when they see them every month or every couple of weeks while patients on chemotherapy. Often when you're off chemotherapy, you're coming in every 6 months, and doctors are worried about, and patients too are worried about what their scans look like, and making sure the cancer's not coming back. But I would say that there are probably 20% of patients who probably never truly get back the cognition that was there. And I think the big fear, and there's no evidence for it, and I don't think anyone here needs to worry about it, but I think a question people always will ask, which we don't know the answer to, is there an increased risk for like Alzheimer's or dementia later on in life if you had chemotherapy early on? And that's something I think there's no research on. I don't think we have any ideas. And obviously these have always been important, but as our cancer therapies have gotten better and patients are living a long time, and cancer in many cases is becoming a chronic disease, or we're actually curing them in some cases, these are issues that are, at the present time, I don't think being looked at, but are going to be huge issues. In the old days, 20 years ago, if you had metastatic cancer, you weren't going to live 5 years. So you didn't worry about these long-term cognitive issues. But this is a huge issue now, but I don't think that piece of research or that sort of interest by the scientific community has caught up with the interest kind of in the treatments that have been improving survivals. Yeah.
Is it, the chances of chemobrain depend on how it's administered, whether infusion or pill form?
So I don't think we truly know that. I think both can cause this issue. Sometimes we think of the pill forms being a little bit less toxic, but sometimes, depending on which pill form it is, some of the pill forms, even though we have this perception they're not, they cause quite a bit of side effects, and some patients will complain that the pill is even worse than the IV. So I think that to answer that question, I don't think we really know, but probably they all have that same potential for cognitive issues. Yeah.
Is there really a blood barrier?
There is. So there is something we call the blood-brain barrier. Normally, it's a good thing, and it's something that probably we all have and was developed to keep poison out of the brain. So, the idea is that the blood vessels that feed the brain have a barrier on their surface that regulates what actually gets into the brain itself. So you can imagine in the old day or ancient times, if someone ingested a poison, you wouldn't want it to actually affect the brain, so it was a great way of keeping things out. When we're treating cancer, though, it becomes an issue because a lot of our drugs that we have or we use for cancer don't get past that blood-brain barrier. So as a result, we can, in many cases, we'll cure the cancer in the body, but patients will still develop some tumors in the brain, and that's because these drugs are not getting into the brain very well. Yeah.
Is there any sort of treatment that is applied directly anyway to the brain and meninges and just that, everything inside?
So if the tumor is actually in the brain itself, for example, for primary brain tumors like glioblastoma, there have been some treatments that have been injected directly into the tumor. And these are like viruses that can be injected directly into the tumor. There have been studies where people have looked at putting drug pumps in where they can infuse drugs in. People have also looked at ways of disrupting the blood-brain barrier. So there are different techniques that can be used to disrupt this barrier, and then chemotherapy can be injected into a vein, and then hopefully it gets in the brain. The problem with a lot of the blood-brain barrier disruption is that it was very toxic to the brain. So there's a lot of issues with like strokes or toxicity from it. So it's become an issue, but there are techniques, so it's balancing it. For metastases, there's nothing that we directly inject into them. Although I think metastases, what's the advantage in treating them, this focused radiation called radiosurgery or Gamma Knife has been I think, a game changer because it's allowed very focused radiation treatments to be administered. The issue is if the more tumors keep coming back, at some point, even though you're zapping different spots, if it just keep coming back, you'll end up having to radiate a large volume of brain, and then it becomes an issue. So there is a lot of need, though, to develop treatments that will get into the brain. Particularly, for example, for something like breast cancer, there have been treatments, particularly breast cancer that has a mutation called HER2 mutation. There's a drug called Herceptin, which has just, I think, revolutionized treatment of that disease because it basically, in many cases, eliminates the tumor from the whole body. But patients, because that Herceptin doesn't get into the brain, there's a risk of it getting brain metastases. So there, fortunately, or hopefully within the next 6 months to a year, there's hopefully another HER2 targeted drug that will be approved by the FDA that actually gets into the brain a lot better. So it's been looked at in clinical trials, and it actually had a lot of benefit for breast cancer with brain metastases. So hopefully that will be approved, and hopefully it will help treat patients who have that issue. Yeah.
Could you just speak to the effects of injecting viruses? I've never heard of that.
Yeah, so one of the issues with primary brain tumors like glioblastoma is that the tumor often invades the brain pretty diffusely. So if you try to do radiation, you're really only hitting a small part of it because you can't even see all the areas where the tumor's located, and the chemotherapy only has limited effectiveness. So the idea is, or people have designed treatments, viruses basically, that are engineered to affect tumor cells. So the idea is that the virus is injected into the brain, it infects tumor cells, and then the advantage is that once it affects a tumor cell, it makes more virus that then is released that then affects other tumor cells. So the idea is that you could inject the virus and it could kind of spread throughout the tumor and kill the tumor. And that the virus is designed or engineered not to affect normal cells. So it's kind of selectively targeting tumor cells.
Any particular virus, or does it have a name, or is it just?
So there's a whole bunch of different ones. Like what was mentioned, the one that got the most publicity was using a modified polio virus.
Oh, okay.
That was they actually had a 60 minutes on that virus, and a whole big thing about it. But they take adenovirus, which is often a common cold virus. That's been used. People have used modified nasal viruses. So basically, a whole host of different viruses have been engineered to try to treat these tumors.
Thank you.
Yeah.
You just mentioned a HER2 disease or medicine that's going to be approved maybe in the next 6 months. What's the name of that?
I've got a blank on it. I knew someone was going to ask me that too. I think it's like tucatinib, or I don't know if you're familiar with that, but I think it's tucatinib or something.
Yeah, I'm not pronouncing, but
that's the drug that's hopefully going to be approved. I mean, it supposedly it's on the road, is what I've been told. So, as long as nothing comes up unexpected with the FDA, yeah, it'll be out. Yeah.
You mentioned white matter abnormalities could come up. Could you speak to what type of abnormalities and how that might affect someone who had abnormalities before they got the cancer?
Yeah, no, it's a good question. So when we talk about white matter abnormalities on MRIs, what I'm talking about is when we do an MRI, if anyone's had one, it takes like an hour. And the reason it takes so long is there's different parts or sequences we do that shows us different things. We do part of it that looks at blood, whether there's any blood or bleeding in the brain. One part looks at if there's a stroke. Another part we get the contrast to see if there's any tumors that take up the contrast. There's another part called T2 or FLAIR, which is kind of a standard sequence in the MRI. And we know that as people age, and even normal, healthy individuals, if we do an MRI, we'll often see little white dots in the MRIs in what we call the white matter. So the brain has gray matter, which are like the nerve cells, and white matter, which are like the wires that connect all the nerve cells together. And in the area where these wires are located in the brain, on normal and patients will often see little white dots that we call just sort of microvascular changes, which basically is a way of saying just like you get your arteries in your heart can develop atherosclerosis, you can develop changes in the blood vessels in the brain. And it's something we see more commonly in patients who have high blood pressure or issues with blood vessels in other parts of their body. A heavy burden of those white matter in normal patients could be associated with perhaps a stroke risk factor. But so often people have that even without having a history of chemotherapy or any type of cancer treatment. But patients who actually develop, who are treated with chemotherapy can develop those type of changes or even more confluent or more obvious changes on the MRI than patients who just have it associated with cognitive issue and aging. Whether patients who sort of have a high burden of those changes at baseline and then get chemotherapy are at higher risk of developing cognitive issues, we really don't know. It'd be sort of an interesting study to look at because, again, I told you we don't know how to predict. You know, if you did a baseline MRI and you saw someone had a high burden of those changes, you know, it would be nice if we could then develop a drug regimen for that patient that maybe would have less risk of developing cognitive issues. But we're so far from being able to do anything like that that we don't really know the relation between the two.
Thank you.
Circulation, is that, your circulation can be affected by the chemo or radiation?
So,
as far as, you know, always having cold feet or hands or...
Yeah, so I don't know if it's so much the circulation that gets affected as much as the nerves that kind of regulate the temperature. So many chemotherapy drugs, their main toxic side effect is neuropathy. So often we're limited how much chemotherapy we can give a patient because of the risk of developing neuropathy or damage to their nerves. So that if there was a way to prevent that from happening, in many cases, it may be safer to give even higher doses of chemotherapy. But that effect on the nerves, it probably can affect some of the small nerves that control temperature regulation and can lead to some of the temperature changes. So I think it's probably not so much circulation as it is the nerves being affected. Yeah.
And those nerves do not come back. I mean, the neuropathy stays.
So it usually will come back, but super slow. So it's often years after the treatment's done. And it's so slow that patients never like come in and say, my neuropathy got better overnight. You know, patients don't ever feel like the neuropathy gets better, but it's the type of thing where if you say like, you look back, oh, a year ago, I've gotten a lot better compared to a year ago, although I have no idea when that happened because there was never a day that I woke up and said, I feel better.
It's gone.
Yeah, so it's just so subtle or so slow. So it's just something, but they can. The nerves unlike the brain, where often doesn't heal if we damage, the nerves in the extremities or in the body can heal, but it takes a long time. And there's no treatment that makes it heal faster.
So there is no treatment, it just does it
It just does it on its own, and it's very slow. Yeah.
My sister mentioned something about low-level light therapy for neuropathy. Have you heard of that?
So I haven't particularly heard of that. I've heard about light therapy for other things, but I haven't heard that as a treatment for neuropathy. Again, it's one of those things, there's probably no evidence that it works. Also no evidence that it doesn't work.
Right.
I suspect it probably doesn't hurt, to get it. Although the question always becomes the cost, and I always get skeptical, especially when someone's charging a lot of money for a therapy that's not really proven or tested, because patients unfortunately are struggling with these issues, and they'll try anything because you just want some relief and will do anything possible to try to get some improvement. Yeah.
You're going to find jobs of answering the questions, but I don't hear the question to start with.
That's exactly what I'm writing down.
The questions are coming from all over the room, different bodies. We can't hear the questions, but you can you repeat the question?
Sure, I'd be happy to, yes. Yeah,
That's what I was gonna say.
yeah. Yes.
I have taken letrozole for a year and a half, and they just gave me this drug holiday because I just had the MRI scan and everything, because I've had a lot of memory issues and word issues, and now they put me on a different kind of, like letrozole, but it's something else. And I've been on it 3 days, but I can already tell that it's clogging me up in the brain. Is that a chemotherapy, or what is that?
Yeah, so her question was, she had been on letrozole, and she actually, they took her off it because it was causing some cloudiness and some memory issues. They switched her to a different drug that's similar to letrozole, and even after 3 days on that treatment, it's causing some memory and cognitive issues. So the question is that chemotherapy, or what type of treatment is that? And that's more of what we call a hormonal therapy. So that's, we use drugs that basically will block hormones if we think that cancer has receptors, or we think that estrogen or progesterone can help make the cancer grow. We'll give drugs to block estrogen or block progesterone, and even those drugs, just as I mentioned sort of earlier on, they've been reported to cause cognitive issues too. So probably it doesn't matter which one of those you take, because they're all doing the same thing, meaning they're affecting hormone levels, and that's probably, even whether you're on one or a different one, it would be, you may experience the same issues on that one as well. Yeah.
I wanted to ask you something, Dr. Rush. Biochamber therapy, the one that you get into the, I don't know how to say it.
Oxygen therapy?
Huh?
The oxygen therapy?
Yes, that. How does that work on people that have brain cancer and that have neuropathy and stuff like that?
Yeah, so the question was, I think you're referring to the hyperbaric oxygen chambers. What effect does that have on patients with brain issues or neuropathy? So one of the issues that can happen when you treat patients with brain radiation is they can develop swelling in the brain and necrosis of normal brain tissue, something we call radiation necrosis. And it's something that it's been a problem or an issue for as long as we've been using radiation for the brain. One of the purported treatments for that is to do something called hyperbaric oxygen. So you probably have heard that if patients, for example, not patients, but if people, divers, come up too quickly, they don't normalize the pressure in the blood with the pressure on the surface. So what happens is the nitrogen in the blood forms bubbles, and they develop something called the bends, which is a whole issue. So basically, there were chambers developed to lower the pressure, and then the pressure can be brought up slowly, so that someone who is suffering from the bends could be they could treat that issue. In addition, we know that at lower pressures, if you're in a high oxygen environment, you can actually get more oxygen into tissue by being in that high pressure environment when you're in the chamber. So it's been used as a treatment for radiation necrosis. So the idea being that if you could get more oxygen into those areas, it may be a treatment for it. It's been used as a treatment for wounds that are not healing. Again, the idea, if you get more oxygen into the wound, it may help with the healing. I wouldn't be surprised if people have tried it for neuropathy. I don't think there's been a good study that's supported it. I would say, I think for wound healing, it may have some benefit. I think for radiation necrosis, the benefit's kind of questionable. We don't use it too much anymore for that treatment, or it's not something I typically refer patients to. I think we have other therapies that are more effective. But it is a way to try to treat necrosis in the brain from radiation or wounds that are not healing.
She had part two.
Yeah.
I do. So that means that if you got necrosis Do you have other treatments for those kind of treatments?
So we do. So I would say more commonly what's used now for brain necrosis is a treatment called Avastin, which is something that's used as a chemotherapy for some cancers. But it also has an effect on necrosis, and probably it does the best job of treating the necrosis compared to any of the other treatments that we used to use. Yeah.
Throughout the literature, I see the letters CRCI. I don't see what those letters
Yes,
stand
good
for.
question. So the question was, when I was doing the talk, you saw this abbreviation CRCI, and it's chemotherapy-related cognitive impairment. So chemobrain's probably the CRCI is, if you read like the medical literature on the subject, that's often the term that they use as instead of chemobrain. But I think all of us and all patients will use the term chemobrain instead. Right.
Thank you.
Yeah.
2 questions back to the chemobrain. Do you know of any clinical trials in progress for it or plan for that? And then also related, do you know of any drugs that are being used anecdotally to treat it?
Yeah, so the question was, am I aware of any clinical trials that are either ongoing or coming soon to treat chemobrain? And then the second part was, if not, are there any sort of drugs or treatments that, we may not have studies, but patients have said, what, this works it makes it better. So I'm not aware of any current trials, at least I don't, in the Chicago area, I'm not aware of any trials right now that is looking at this issue. Whether there's a trial going on, like at MD Anderson in Houston or at Sloan Kettering in New York, I'm not aware of them. I don't know of any drug that's anecdotally been, shown to be effective. I would say what's shown to be the most effective probably is exercise. Obviously, that's something that's hard to do sometimes if you're having, a lot of fatigue or you're having other issues related to the cancer. But exercise seems to be the anecdotally, or even in studies, the most effective treatment that seems to be out there for this right now.
Are you saying physical or mental game
So
exercise?
really more, actually physical. Even though that's kind of counterintuitive, it's more physical. So that could be walking, could be yoga, could be, even more, more strenuous exertion. But it seems to be physical activity seems to be the best. By no means is it a cure, but often I think that ends up being the best treatment.
Because they kept me on treatment. I have chemobrain. I just faced right there. And mostly it's like mental game plays and stuff like that.
I mean, I think that it can be helpful. I don't think it's ever been shown to be like an effective treatment. But again, it's something that doesn't hurt, and we know for things like preventing dementia or preventing other cognitive issues, keeping your mind mentally sharp and mentally active seems to help. So,
like Jeopardy?
Like Jeopardy, right?
Jeopardy.
Susie, is there anything nutritionally that seems to help? And you've talked about a lot of drugs, but methotrexate being a drug that's more heavily for chemobrain.
Yeah, so it was a 2-part question. The first part was, what was it?
Nutritional.
The first question was, is there anything nutritional or any type of diet that seems to be helpful? And the second part was, is the drug methotrexate like a particular culprit in causing cognitive issues? So the first part of the question is that there's no diet that's been shown to be beneficial. I can tell you that in my experience, just like for weight loss, there's a new diet that comes out every 2 to 5 years, and that becomes the new fad, and that's what everyone's using. And then all of a sudden, that's kind of forgotten, and then there's something new that comes out.
They don't eat sugar and don't.
Yeah, I don't think that the popular diet now is the keto diet, ketogenic diet. It's a diet that is low sugar, low carb, but I think for this issue of the cognitive issues, I haven't seen any benefit, or I don't think, there's no studies, no reputable studies that show that that particular diet preserves cognition or reduces the risk of cognition issues. I can tell you, I can't remember what the diet was, but 10 years ago there was something completely different that people believed and would do for that. So I don't think there's one. To answer the question about methotrexate, so that is a drug that, particularly in high doses, has a higher risk of causing some cognitive issues. So a couple things with that drug. One, in virtually every patient who gets high-dose methotrexate, we see changes on the MRI in the white matter, kind of like as I talked about early, but they all develop sort of confluent areas of white matter dysfunction after the methotrexate. So, and often it's because we're giving it at mega doses to get it into the brain. So
It's better to break the brain, that's one of the...
it gets past the blood-brain barrier because we can give it at a very high dose with a very rapid rate of infusion to push it past the blood-brain barrier. And in addition to that, there's a sort of relationship with radiation and methotrexate that is sort of synergistic, or when they're combined together, patients could have even more risk of developing cognitive issues. So that I can tell you that there's an issue with relationship of the radiation to methotrexate. So we usually like to give methotrexate before radiation, because if patients get radiation and methotrexate together, they virtually all have severe toxicity. If we do the radiation first and then do the methotrexate after, there's increased risk of toxicity. And even if we do the chemotherapy, the methotrexate first, and we do the radiation after it, if patients are over the age of like 55, there's a very high risk of developing cognitive issues after it. So there is, that drug particularly does have some issues with cognition.
In nephropathy, you don't think B6 would help?
So the question was, does B6 help with neuropathy? So people have looked at all kinds of different vitamins to treat neuropathy. Vitamin B12, B6, B1, but in all those studies where vitamins have been looked at, none of those drugs effectively prevented neuropathy, and none of those drugs treated neuropathy. With that being said, if someone has neuropathy due to what we think due to chemotherapy, it's probably worth checking a B12 level, because patients who have low B12 levels can develop neuropathy, and that's actually very treatable by either B12 injections or in some cases oral supplementation. So, you know, even in patients who have neuropathy, we think it's from the chemotherapy, it is worth doing some basic blood tests just to make sure that we're not missing an easily treatable cause of the neuropathy. Yeah.
Is there any significant incidence of late onset chemobrain where it would happen after treatment?
Yeah, so the question is, can chemobrain happen after the treatment's done or late onset afterward? And I would say the answer is we really have no idea. It's not been reported, but I don't think that's something that's assessed very well in patients, meaning that, you know, you could imagine that perhaps it could be a long-term issue, just because, just like we know that patients who get chemotherapy, they could be years later at risk of having other toxicity that was related to the early exposure to it. But the answer is we don't know, and it's hard because sometimes people develop cognitive issues and you don't know if it's because, you know, as they got older they developed dementia or some other issues, but the answer is we don't know. If you read anything, they'll say that you won't develop it later on, but I wouldn't be surprised if there's a small population of patients who do develop some late onset, you know, issues from that. Yep.
Are you guys starting to find out that particular chemo drugs are affecting certain nerves? For example, are certain chemo drugs that we're all treated with will create neuropathy, or in my situation I found out that carboplatin wound up attacking my inner ear vestibular system, where I'm having balance problems. So are they starting to see a connection?
Yeah, so with cognition, we don't really have that association. The question was, are there certain drugs that seem to affect neuropathy, or are we starting to determine which ones cause neuropathy? To answer that particular question, for neuropathy, we do know the drugs that are most likely to cause neuropathy. So that's something that is well known and has been well established. So for example, you mentioned the drug carboplatin. Just kind of the name sounds, it's platin, it's based on a platinum molecule. And you think of platinum, it's a heavy metal. So basically when you're getting carboplatin, we're basically giving you heavy metal poisoning. And as a result, we know that heavy metal poisoning can cause damage to nerves and damage to the inner ear. So we do know, I think neuropathy, we're very well aware of the drugs that cause neuropathy. And there are certain drugs like the platinums, the Taxols, the drug called vincristine, which are well known to cause a lot of neuropathy.
Is there any connection between methotrexate and neuropathy?
So the question was, is there any connection between methotrexate and neuropathy? So usually no. Methotrexate has its own potential side effects. Usually neuropathy is not one of the side effects from methotrexate.
Well, does it matter if you're getting methotrexate by orally with a pill versus an injection?
Either way, it's just not a side effect that patients typically get from that drug.
Thank you.
Yep.
Is there any studies that show any difference in the, I guess, chemobrain for more or less for proton versus, is it like a photon?
Yeah, so the question was, is there any sort of evidence or studies that show that patients will have less cognitive effects if they get proton radiation versus photon radiation?
Or any other types?
Or any other types. So the answer is so the answer is there's early studies that suggest that. Proton's just been around for maybe 10 years, a little bit longer. I told you about Gamma knife for radiosurgery. That likely has less effects. I think the way to think about it is that even without studies, we know that the larger volume of your brain that you radiate, the more risk you are to develop toxicity. So whether you get whole brain radiation with protons or photons probably doesn't matter because you're radiating the whole brain. The advantage of proton is that you can give the radiation much more focused if you're only treating a focused area. So we talked, someone had mentioned types of primary brain tumors like glioblastoma. We typically don't treat those patients with whole brain radiation. We typically just treat them with radiation to the area where the tumor is. And with photons, or which is considered standard or traditional radiation, even though we're just targeting that area, there is some radiation dose that will hit the surrounding areas. Because what happens is the radiation beam hits the tumor, but there's still radiation that passes through the tumor and goes into the surrounding brain. So even though it may not be a high dose, there's still some dose that's there. With proton, we can just treat that tumor and we spare all the normal brain. So particularly in children, it's really what's being used now. If a child needs focused radiation, pretty much it's always done with protons, just to try to reduce their risk of developing cognitive issues. In adults, we have less sort of data available, and because it's a very expensive treatment, often insurance doesn't want to pay for it, so it's often a challenge in trying to be able to use that in adults. Yeah.
You mentioned earlier, it was just kind of a mention that you had of later toxic effects from chemo that come up later. What would that be?
So the question was, what are some later toxic effects of chemotherapy? What would that be? Could be effects on the immune system. Often after you take chemotherapy, your immune system's never the same again after that. So maybe at more risk for infection, maybe more at risk for issues as a result of that. Depending on the type of chemotherapy you get, there's a risk of developing a second cancer actually caused by the chemotherapy. Chemotherapy affects normal cells, and it can, in some cases, cause mutations in those normal cells that could lead to a risk of developing second cancers later on in life. It can lead, as was mentioned earlier, it can have effects on the inner ear, on the nerves. Could be effects on the kidney that usually those happen during the treatment, but can kind of show up soon after the treatment's done. So there can be some longer term issues from different chemotherapies. Yeah.
Are they finding with radiation, I know to the brain is more your specialty, would that affect like the endocrine system, like the thyroid being so close?
Yeah, so the question was, does radiation to the brain affect the endocrine system like the thyroid with it being so close? So I would say the biggest risk from an endocrine standpoint with brain radiation is to the pituitary gland. So your pituitary gland produces like 6 hormones, including something called TSH, or thyroid stimulating hormone. And what that is, that's the hormone that actually tells the thyroid to release thyroid hormone. So what can happen is the pituitary is actually vulnerable to the effects of radiation. So if it's in the radiation field, it's something that it doesn't happen during the radiation, but it's something that could be a side effect like years after the brain radiation. So kind of like with chemotherapy maybe having some long-term effects, radiation on the brain can have some long-term effects too, and one of those is on the pituitary gland and the hormones that it produces. Yeah.
Do you find that also the thyroid with chemo? Because I was hypothyroid after my treatments, I never had an issue. And it's more radiation related, right? Or is it?
Yeah, so the question was, can you become hypothyroid after chemo? I don't know the answer to that, to be honest with you. Definitely radiation to the thyroid can cause issues. I don't know about if there's certain chemo drugs that are more likely to cause hypothyroidism. I'm not aware of it. I can tell you that the immune therapies that are being used now are immunotherapy. These are drugs that stimulate the immune system. These are drugs like Keytruda, Opdivo, Yervoy. Those drugs can actually cause autoimmune reactions that could cause hyperthyroidism is a somewhat, I don't want to say common side effect, but of side effects that patients experience, that can be a more common side effect of that drug.
What's the difference between the hypothyroid and the hyper?
Yeah, so the question was, what's the difference between hypothyroid and hyperthyroid? So hypo means you have decreased thyroid function. Hyperthyroid means your thyroid's working too much. So it's bad in both ways, right? You want it working, but not too much, but you don't want it working too little either. Yep.
Does chemotherapy often cause a problem with the kidneys?
So the question was, does chemotherapy cause a problem with the kidneys? Again, it depends on the drug. There are certain chemotherapy drugs that one of the side effects is toxicity on the kidneys. So just a couple examples of that. One was the methotrexate that was mentioned. That's one of the big risks of methotrexate, is it can cause kidney failure. It's also, someone mentioned carboplatin. Not so much carboplatin, but a cousin drug called cisplatin. That can have some toxicity on the kidney. So there are certain drugs that can affect the kidneys.
Isn't the liver become a fatty liver, possibility to become a fatty liver too because of it?
So the question is, can you get fatty liver because of the drugs? So you can have different types of liver toxicity because of the drugs too. It could actually cause liver damage, perhaps fatty liver. To be honest with you, I don't know 100% the relationship or association between different chemo drugs and fatty liver, but it may be a possibility. I'm just not aware of that. Any other questions? I think we're right at the 7 o'clock hour. Oh, one more.
So chemo brain may never go away?
So I think in some patients it may never go away. And if it does, it may be, again, just like the neuropathy, something that's very slow, that takes time to get better. But I do think there is a subset, probably 20% of patients with chemo brain, that it never goes away completely. And then it's just a matter of, I think, developing strategies to deal with it, kind of what we talked about earlier, routines, writing things down, kind of those sort of organizing strategies. Great. Well, thank you for coming tonight. I really appreciate the chance to talk to everyone.